Thank you very much for the invitation. I will show you a case of TAVI implantation patient that we did orbital atherectomy in order to facilitate TAVI. It was a 77-year-old patient with claudication, which they implanted a stent in the right common iliac artery. He had also coronary artery disease with stent implantation in all coronary arteries. And we scheduled him for TAVI implantation through the left femoral artery. You see here that it's very calcified, and the left and the right. Here is the stent in the right common iliac artery. It's very narrow, and we chose to go from the other leg because we didn't want to mess with the stent. Here you see that there is a big nobule of calcium. So that's why we chose not to proceed with balloons or shock wave and go to orbital atherectomy in order to crack this calcium and debulk it also. You see here is a picture. The lumen that we had is this narrow, dark line. The calcium is all this behind the artery. And you see it here in this video also. You can see it better, I think. So what we did orbital with the large crown. The orbital for the peripheral is a little bit different than the orbital for the coronaries. It has 3 different crowns. This is the large, the extra large, the largest crown that exists. And it has also 3 different speeds. But the principles are more or less the same. After orbital, we did several runs of orbital. After orbital, we inflated a balloon in order to crack more the calcium. And after ballooning, it was quite easy to insert the eye sleeve. And the implantation, I don't have to make any comments about the implantation. It was an easy implantation, no worries with that. So challenging TAVI cases may need also other techniques in order to facilitate the implantation, and orbital atherectomy may be a useful tool towards this direction. Thank you very much.
Thank you. It's a very nice case, stressing, in my opinion, 2 things. A, the boundaries of what we can do with transcatheter ways are increasing, because 20 years ago or 10 years ago, we would say, no access, go to surgery, or go transapical, very, very easily. A, we can do more things transfemoral, and nowadays TAVI equals transfemoral TAVI in guidelines and everywhere. And second, can I ask you, the e-sheath went in easily. Did the valve through the e-sheath, when expanded, also went in easily, or did you have to push?
Yes, it was very easy.
So it was very adequate.
I had my plan was to dilate also in the sheath, but I went through the lesion so easily, so that I said, okay, I will try it this way, and it was straightforward case.
Because sheath and valve are 2 different things. A comment? Yes.
That was also my question. Thanks for the invitation. Great case. What, in your opinion, how did you choose this approach instead of surgery, for example?
Instead of?
Surgery or another?
Surgery is not an option. Okay. So a 77-year-old patient, obese, with claudication, it was not in our option. The only question was how would we do it with TAVI. And we thought that instead of using shock wave or balloon inflations or going from the right leg that had the stent, we chose to do orbital. We had the experience also from the coronaries.
Okay.
So if you know how to use this method, you feel confident to apply it in the peripherals also.
Because it was difficult, so congratulations.
Thank you.
Did you consider an alternative access route, like carotid or subclavian?
No, because I thought that I would manage it from the leg, so I didn't check for other routes.
Okay, I think it is an excellent indication. We have nowadays so many options to modify calcium. We have high-pressure balloons, we have shockwave balloons, we have rota, we have orbital. This was a perfect indication for orbital atherectomy. It's textbook. It was perfect indication. It was perfectly executed, leading to a good result. So thank you.
You're welcome.
I have to, unfortunately,